we are going to move on to deliver the rest of this morning's presentation. My colleagues Deanna Field and Sharon DeSantis are going to join me and present the information on some of the new and changing regulations in Pennsylvania. As we pull up our topics, you'll see that we're going to talk about, in addition to regulations, we're going to talk about public health, and that specifically is coronavirus. Then we're going to tell you the latest about some coding changes, more information coming from Medicare and Medicaid, plus some updates from other payers. Then we're going to wrap it up with some new information that has emerged on health information technology. There's a lot to discuss. I know we're running late, but it's really, we appreciate that you have stuck with us this long. And if you have to go at 12, I understand. I just want to remind you that this webinar is being recorded and will be available for viewing later on. So if you have to step away, we understand, but we're glad that you've stuck with us this far. So let's jump into the regulations. If we can pull up the next slide, please, that would be great. I'm going to kick this off with some background information on Section 1557 of the Affordable Care Act. There's been some changes. So Section 1557 builds on the longstanding protections against discrimination, and it provides non-discrimination requirements for covered healthcare entities, and that includes most medical practices. In general, Section 1557 prohibits discriminating against based on race, color, national origin, which includes limited English proficiency, age, disability, sex, and there's been some changes to that recently. So on June 12, 2020, this year, HHS published a final rule which revised some previous regulations that were issued back in 2016. The rule eliminates the mandate for entities to send patients notices and taglines in 15 or more languages. It repeals the requirement for each covered entity that has 15 or more employees to have a compliance coordinator and to have a written grievance procedure to handle complaints. The rule also eliminated the need for covered entities to have a language access plan. And finally, the rule also repealed the provision for compensatory damages and the ability to sue. So HHS has stated that it will continue to enforce the federal civil rights laws that prohibit discrimination on the basis of race, color, national origin, disability, age, sex, in healthcare. But the final rule also retains the protections for non-English speakers, including the right to meaningful language access to healthcare. It also maintains the qualification standards for translators and interpreters, and also the limitations on the use of minors and family members as translators in the healthcare setting. So this final rule became effective August 18th, 2020. Next slide, please. So this is a renewal year for medical licenses, and your physicians should receive renewal notices about 60 days before the deadline. The items that you see on the screen are for you to remind your physicians about the steps to renew their licenses. First, your physicians should make sure that their PALS account is up to date. The link to PALS is on the slide. Be aware of the deadlines and fees related to the renewal. Your physicians should have completed their CME. We've heard Janet at the very beginning of the program this morning talk about our CME resources. If you need, if your physicians need CME, make sure that they are coming to PAMED to get those requirements fulfilled. We also have the education on opioid prescribing and identifying and reporting child abuse and more. Also, be sure that you allow enough time for the application to be processed. The license is not considered renewed until the board processes and officially renews it. Next slide, please. So you're going to see a little bit of, interesting information here, the way, things play out. For physicians across Pennsylvania, this is going to apply to both MDs and DOs to renew their license. It's a biennial cycle, and it's every even numbered year, 2020, even numbered year. For DOs, the renewal deadline is October 31st. For MDs, the renewal deadline is December 31st. Now, the cost for DOs to renew was increased to $330 this year. Now, for MDs, at its September 2020 meeting, the State Board of Medicine voted to waive the renewal fees for MDs this period. So more information on this waiver is going to be included with the MD's renewal notices, and they're going to be emailed early November is what we're anticipating. Next slide, please. I just want to give you a quick update on venue. You've heard us talk about this at every admin meeting for the past couple sessions anyway. And on September 8th of this year, the Senate Judiciary Committee Chairwoman Lisa Baker held a public hearing to review the report from the Legislative Budget and Finance Committee. That came out in February of 2020. So that LBFC report was directed to study the impact of the proposed Pennsylvania Supreme Court venue rule change, which PAMED and its coalition of stakeholders vehemently opposes. What it would do is allow medical liability lawsuits to take place outside of the county where the malpractice allegedly occurred. So PAMED believes that if the current common sense venue rule is changed, that it's going to have the potential to return Pennsylvania back to the crisis of the early 2000s, where there was decreased access to care for patients and driving healthcare costs, particularly in the liability realm. So we're going to continue to watch the issue, and we'll provide updates, as things progress. Next slide, please. I want to give a brief mention to telemedicine. We talked a lot about it in the spring. That was an ever-changing, it felt like, topic where new information was coming out all the time. There have been many interim policies that have been put into place where they were expanding telemedicine, and those policies, for the most part, are still in effect now. Most, if not all, payers have implemented these interim policies, and they've been extending them as well as the public health emergency continues. We're finding that most policies have end dates that fall somewhere between September and December. Other payers we've seen have tied their policies to the duration of the public health emergency, which right now has an end date of October 22nd, unless it ends up being renewed again. We're hearing from some feedback from payers about telemedicine, and unfortunately the payers have different policies, and so that means that the billing is not standardized. So the payers, the feedback has been, well, we need to re-educate everybody. Well, it's not that easy when, you have many different payers with many different policies and there's no uniformity. So I just want to share a reminder to you to, some things to watch for. Watch your modifiers. Some payers require either the GT modifier or the 95 modifier to indicate that it's a telemedicine claim. The description for that modifier is that synchronous audio and video telecommunication was used. What does synchronous mean? It's the real-time connection between that uses audio and video technology. I also want to warn you to watch your place of service code. Some payers allow the place of service to reflect where the service would have been, such as in an office if it had been rendered face-to-face. Other payers require the place of service code of 02 to reflect that the service was rendered via telemedicine. So keep in mind that these are going to vary from payer to payer. I also want to mention telephone services. As some payers are covering specific telephone services codes. Some are allowing audio-only policies for your standard E&M codes. Become familiar with those policies. Be sure to review payer policies, as you're billing these claims. Next slide, please. this is going to bring me to some interesting news. Now, I have not heard about this in Pennsylvania yet. I heard about this through a contact in another state, and I'm sharing it with you today only as a precaution. If you start to experience any of this, please reach out to us. What I've heard from the other state was that payers are starting audits of telemedicine claims. It seems that payers are looking at E&M codes, 99201 through 99215, and they want to ensure that real-time audio and video technology was used to conduct the visit. Payers are also auditing the visits that were billed at level 4 and level 5. So as they're auditing these telemedicine records, payers are looking at documentation. They want to see what platform was used to conduct the visit. They also, believe it or not, payers are also checking with patients to confirm whether audio and video was used for the visit, and if the technology platform was HIPAA compliant or not. If it was not, payers are also checking to see if the patient was alerted to privacy risk. And they're referencing the OCR's notification for the enforcement discretion when using non-HIPAA compliant technology. So I included some of the language from the OCR. The notice states that providers are encouraged to notify their patients about privacy risk. It doesn't say required. So I just wanted to share what's going on in another state. If you start to experience similar things, please reach out to us. Please let us know. Next slide, please. Just a quick mention about the Provider Relief Fund. You heard us talk about this back in April. At the time, we're only in phase 1 of those funds being released. We are now talking about phase 2. So this is related to the CARES Act, the Coronavirus Aid, Relief, and Economic Security Act, which brought about the Provider Relief Fund. It is aimed at supporting healthcare providers during the COVID pandemic, and providers may receive Provider Relief Fund payments that are either related expenses or lost revenue due to the pandemic. So these distributions do not need to be repaid to the U.S. government, assuming that you comply with the terms and conditions. So all of the recipients of these Provider Relief Fund payments are required to comply with all of the terms and conditions. And there's also a segment in there about reporting requirements as well. So we don't have a lot of information on those reporting requirements. They are going to be specified in future direction, as we go through the fall, and they'll be coming from HHS. Now, what those reporting requirements refer to are reports that are going to detail how the recipient used the provider relief money. So like I said, it's used to cover lost revenue or the expenses that were related to purchasing or preventing or preparing for the pandemic. And that's specific to providers who received more than $10,000 that will have to submit those reports. So more information is coming. Stay tuned to our communication avenues for that, such as our weekly newsletter and meetings such as this. All right, next slide, please. So given the COVID pandemic, many children have not obtained vaccinations on the appropriate schedule and may not have what they need in order to attend school this fall. So the Department of Health is temporarily suspending the regulations, which provides the list of immunizations a child must have for the grades, for which they must have them. And these regulations have been suspended for a 2-month period since the beginning of the school year. So, for many cases, that's the time frame that we are in right now. And next slide, please. This is where I'm going to turn it over to my colleague, Deanna Field, who's going to pick up with some more of our topics this program. Deanna?
Thank you, Jen. All right, so I'm going to go ahead and start with that one question that we had earlier with Patrick. was the brand new code 99072. Effective September 8th, the American Medical Association added a new code 99072 for costs of additional supplies, materials, or clinical staff time used over and above what was usually would be included in an office visit or other non-facility service while performed during the PHE as defined by law due to respiratory transmitted infectious disease. So to simplify, code 99072 is used to report the additional practice expense necessary in an office visit or other non-facility setting to mitigate the transmission of the respiratory disease for which the public health emergency was declared. These include, but are not limited to, additional supplies, such as face masks and cleaning supplies, as well as clinical staff time for activities such as pre-visit instructions and office arrival symptom checks that support the safe provision of evaluation, treatment, or procedural services during the respiratory infection-focused PHE. When reporting 99072, report only once per in-person patient encounter per day, per provider, regardless of the number of services rendered at the encounter. Now, since this is so new, we're not hearing of any any payer that is reimbursing currently, as it's too early for any policies. This is just an announcement to keep you informed and so you keep your ear to the ground so you are aware when more information becomes available. Next slide, please. Now we're going to jump into the proposed rule that portion of this that was finalized in 2020 to begin January 1st, 2021. Together, the AMA and CMS have achieved the first overhaul of E&M office visit documentation and coding in almost 30 years. Excuse me a moment. Thank you. These revisions that I will be going over in the next several slides have the potential to significantly reduce physician burden and improve patient care. The CPT and the RUC workshop worked to change the current coding and documentation requirements to simplify the work and improve the health of the patient. The new guidelines are based on these guiding principles: to decrease administrative burden by eliminating scoring of history and exam, decrease the need for audits by having more detail in CPT codes to promote coding consistency, decrease unnecessary documentation not needed for patient care to get rid of note bloat in the medical chart. They created codes for the actual work done regardless of the specialty. It's important to note that these new guidelines I am going over only pertain to E&M office visit codes 99202 through 99215. As Patrick mentioned earlier, the 99201 will be eliminated for 2021, as it was rarely used, and since both 99201 and 99202 require straightforward medical decision-making, it was decided to retain 99211 as it is often utilized for nursing or brief visits. Components of code selection will be based on medical decision-making and or total time on the date of service. History and exam will be documented as medically appropriate, but will not be used in the E&M level selection. Thank you. Next slide. It's important to know that all of these other rules that you have come to know as requirements in documentation and claims will remain unchanged for 2021. And since these changes for 2021 are only specific to E&M office visits, there will be no changes to documentation for services in the hospital, emergency department, or nursing homes. Next slide, please. The most important concept that will not change, and in fact will even become even more prominent, is in the codes for code selection, is the concept of medical necessity. It's an important topic and worth taking some time to review the meaning and intent of medical necessity. Next slide, please. Here is AMA's definition of medical necessity. AMA is really addressing the plan and what the provider decided to do while caring for the patient. Next slide, please. CMS's definition is here on the slide, and they really want to know, did the provider truly address the problem? As CMS states, medical necessity is the overarching criterion for payment. They also emphasize how documentation is so important so that anyone reading the chart understands what happened during the encounter to support the reported services. Next slide, please. Diagnosis selection is a key element in all claims to support medical necessity and reflect the severity of the conditions of the patient. Following the components list in the ICD-10 book will help defend the CPT codes. The new E&M guidelines and the definitions provided for assessing the problems addressed provide a good basis to help with the understanding of medical necessity and with determining which ICD-10 codes should be reported for that encounter. Diagnosis codes are an important and sometimes misunderstood aspect of correct coding. Improper diagnosis coding can lead to claim denials and other missed revenue opportunities. It can also make the practice a target for audits and expose it to risk. Next slide, please. So let's describe one of the new changes to determine the level of service using time. Billing a claim for time will include the total time on the day of service, not time the day before or the next day. Services must include a face-to-face with the billing reporting provider to include time for any services while not spent directly with the patient. Total time reported should not include any time for services performed by the clinical staff. Documentation should have a statement of total time and the activities that were performed during the encounter. Thank you. Next slide. Here is a list of examples that can be used for calculating total time for services if they are performed on the same day as the face-to-face with the patient. You will see in the green, not separately reported. And what is meant by not separately reported? This is a very important concept when using time, as there is no allowance for double dipping. If the reporting provider can bill separately for a service that includes some of these time elements, then the time to perform that service should not count toward the total time. An easy example would be a provider that is able to perform an X-ray in the office. If the provider orders an X-ray and reviews the image and documents the findings, then the time spent in the interpretation and reporting is not considered a part of the total time because the provider will be paid for that in the interpretation when the code for radiology is reported on the claim. Thank you. Next slide. Continuing with the new changes for 2021 for shared or split visits, as it only relates to E&M codes 99202 through 99215, not the hospital. The AMA did address the situation. Many practices employ non-physician providers and have situations in the office where a split shared visit concept is appropriate. The AMA takes the following stance on this topic. Time can only be counted by the provider for the work done personally. So if the physician and the non-physician provider are in the room at the same time, the time of one can be counted. Let's say a nurse practitioner saw the patient alone and the medical doctor saw the patient alone. Then the time can be combined and billed under one provider. When time is being used to select the appropriate level of service for which time-based reporting of shared or split visits is allowed, the time personally spent by the physician and other QHP assessing and managing the patient on the date of the encounter is summed to define the total time. So again, this is a reminder of how important documentation is. If time is not documented well, the biller may need to consider using medical decision-making when filing the claim. Thank you. Next slide. So coming to the end of the time requirements for selecting the E&M selection, before we move on to medical decision-making, this is your time chart requirements when using time to select your E&M level selection from 99202 through 99215. Next slide, please. So now let's move on to the second component of selecting level of service through medical decision-making. The elements of medical decision-making changes for 2021 are similar to what exists now, but there are key words that have been added to better define what actually occurred on the date of service. So for the first element, number and complexity of problems, I'd like you to add these words, addressed at the encounter. So it should read, the number and complexity of problems addressed at the encounter. For the second element, the amount and complexity of data to review has the added word analysis or analyzed. The third element, risk of complications, morbidity, or mortality, please add the words of patient management. Now to reflect the risk of complications, morbidity, and or mortality of the patient management. I will go into further details on these points as we look at each element in more detail. Next slide, please. Complexity of problem addressed is based on CMS's documentation guidelines table of risk, with new additional guidelines and numerous definitions to select the complexity for problems addressed at the encounter. Next slide, please. The decisions for changes for this element of data reviewed and analyzed on the date of service is for the purpose of the physician and the QHP to spend more time documenting a report to be clinically centered on the patient with the goal to eliminate note bloat and cutting and pasting of data not reviewed and analyzed on the date of service. There are three categories of data: test, documents, or independent historian. Each unique test to be counted to meet a threshold number, but to be sure not to count any data reviewed from old notes. Next is independent interpretation. After that, would you please add the words not separately reported? Similar to my X-ray example for time, I used for counting time. Another example would be an EKG performed and interpreted in the office. This would not be allowed to be counted in the data threshold. However, if a patient were to go into an imaging center for a stat X-ray at an imaging center separate from the doctor's office, and then they come back and the physician interprets that, that could be counted as he or she is not billing for that X-ray. Next slide, please. Complications, morbidity, and or mortality of the patient management are the decisions made at the visit associated with the patient's problems, the diagnostic procedures, and treatments. This includes the possible management options selected and those considered but not selected after shared medical decision-making with the patient and or family. For example, a decision about a hospitalization includes consideration alternative levels of care. So it also addresses the risks associated with social determinants of health. Thank you. Next slide. There are 4 levels of medical decision making, and all of these elements that we have discussed fall into one of these categories to select the level to bill. So you have straightforward, low, moderate, and high, and you'll see how that reflects where that falls, what level CPT code, depending on whether it's an established or new patient. So I can quickly go over how these problems and data and risk all fall into it. So if you have a straightforward level, your problem list is self-limited, meaning it can probably heal on its own. For counting data, there would be minimal or no data at all reviewed, and the risk would be minimal. For low, the problem is stable, uncomplicated, or possibly a single problem for counting data. It requires 2 documents to be reviewed or an independent historian. The risk level is low, minimal, consistent if of discussion. Moderate, the problem is multiple problems or significantly ill, and counting data is either one of these 3. They can either review 3 documents, interpret, or confer with another QHP, and the risk would be moderate. And you would be reviewing that with a patient or monitoring or considering elements of social determinants of health. If the code falls in within the high element, the problems are the patient would be very ill, and counting data is either 2 of the 3 categories. 3 documents reviewed and interpreted, confer with another QHP. The risks will be high, and possibly the discussion would need to discuss possible poor outcomes and watch and monitor. Now, we provide links all the time on our slides, and I hope you find them helpful. But this link on this slide will bring everything I've discussed together. It's all laid out and broken down in a chart with definitions on every section. I highly recommend you click and print on this information and share it with your providers at your office. Now is the time for your physicians, QHPs, and billers to get familiar with the AMA guidelines now, to get a plan in place, and everyone can be on the same page. We have heard that there are still some gray areas, and I'm sure we'll continue to get updates from both CMS and AMA. So the AMA E&M guidelines is on the bottom of this slide, and it's a very useful guideline for all of the information that I've just gone over. Thank you. Next slide. So moving on to some more Medicare news, the appropriate use criteria due to the COVID-19 public health emergency has been delayed. They just announced that very recently, and it is pushing back the mandate for referring providers to use the appropriate use criteria and clinical decision support tools. Now the testing period for physicians who order advanced imaging scans has been extended through the end of 2021. CMS announced the AUC educational and operations testing period extension through calendar year 2021 on August 10th statement. And I believe that you will find more information in our quick consult that has recently been updated, and it is on the link on this slide. A reminder, there will be no payment consequences associated with the AUC program during calendar year 2020 or 2021. And they encourage all stakeholders to use this period to learn, test, and prepare for the AUC program until full implementation on January 1st, 2022. Thank you. Next slide. On March 30th, CMS suspended most Medicare fee-for-service medical review because of the COVID-19 pandemic. As states reopen and given the importance of medical review activities to CMS's program integrity efforts, CMS has discontinued exercising enforcement discretion beginning on August 3rd, 2020, regardless of the status of the public health emergency. If you are selected for review, providers should discuss with their contractor with any COVID-19 related hardships they are experiencing, which could affect the audit response timeline. CMS notes that all reviews should be conducted in accordance with statutory and regulatory provisions, as well as related billing and coding requirements. Waivers and flexibilities in place at the time of the dates of service of any claims potentially selected for review will also be applied. Link on the slide for more information. Thank you. Next slide. CMS authorized under the public health emergency the expansion of accelerated and advanced payments, known as AAP, to a broader group of Part A and Part B providers and suppliers impacted by unforeseen expenses or losses of revenue attributed to the 2019 novel virus corona-19 pandemic. The purpose of the AAP is to issue necessary funds to providers or suppliers experiencing disruptions in claim submissions and or claim processing. AAPs were issued to Medicare providers and suppliers who submitted a request to the local MAC and met the required qualifications for the AAP eligibility. So for those that have applied and received advance payments from CMS, this information pertains to you. This is 100% recoupment of Medicare reimbursements until the AAP is repaid in full. Repayment begins 120 days after the payment has been issued. The offset is taken from the total Medicare reimbursement listed on the remittance advice. So this means claims submitted will be applied to the balance due. If there is a balance after 210 days, letters will be sent looking for balances due. There's an FAQ for the AAP found on this link that will go directly to Novitas for more information. Thank you. Next slide. For those that submit claims to Novitas, are you aware there is a quick way to correct a claim on your own? It's called Reopening Gateway with Novitas. It's free, and there is no account enrollment required. It allows for almost 10 items that you can correct after you have submitted a claim. After completing provider verification, you'll receive a one-time PIN number to access the claim to correct. The link is here to find an FAQ and a user manual. Thank you. Why is payment being made available for healthcare providers to counsel patients to isolate or quarantine at the time of COVID-19 testing? Models have shown that when patients tested for COVID-19 are placed in isolation immediately while waiting for test results or on the onset of symptoms, additional disease transmission in the community may be reduced. By having patients isolated 1 to 2 days earlier, spread of COVID-19 can be reduced significantly. Modeling shows early isolation can reduce transmission by 86%. Payment is available for counseling of patients that are both Medicare and or Medicaid, recipients under the existing payment policies. These services are also available via telehealth appointments. Please refer to your E&M codes to select the appropriate code selection. CMS has provided many resources that are available on the links on this slide. Thank you. Next slide, please. Starting this summer, some of the, we're moving on to Medicaid, by the way. Okay, starting this summer, some medical assistant beneficiaries may present an updated access card at your office. Here on the slide is a sample picture. The new design has been developed to better inform, the new card will display the same information as before, but it will no longer have the magnetic signature strip on the back. And it's designed to better resemble a commercial health card. Not all MA beneficiaries will be receiving this new card. New cards will only be sent to if a beneficiary is new to the MA program or needs a replacement access card. Other beneficiaries may still present previously issued cards. Both styles should be accepted at your office. And this is a friendly reminder that you still need to check the beneficiary's eligibility through the eligibility verification system. Please refer to the MA bulletin on the link for more information. Thank you. Next slide. On July 8th, 2020, Pennsylvania Department of Health and Services announced applicants selected to deliver health care through Health Choices, the medical assistance physical health managed care program that provides care to more than 2.6 million Pennsylvanians. As of July 9, 2020, the non-selected applicants filed protest for their non-selection. As a result, DHS is prohibited from moving forward with the readiness review process or executing new agreements until the protests are resolved. Applicants were selected through a competitive procurement process that evaluated applicants' soundness of approach, personal qualifications and staffing, and prior experience and performance. Applicants selected were the top scoring applicants for their zone. The chart is listed by zones and the MCOs currently delivering care, as well as the anticipated MCOs that could begin providing services on January 1st, 2021. We will keep you updated as we learn more information. So we have the zones, we have the zone Southeast, the Lehigh Capital, and Southwest. Next slide, please. And we have the next slide, which is Northwest and Northeast. So you have the current MCOs and the anticipated MCOs that did win the procurement. We'll see what happens after those protests have been settled. Next slide. Okay, you've heard about the resource and referral tool in previous presentations of ours. The resource and referral tool, when implemented, will allow providers to assess an individual during a physician's office or emergency department visit, or when receiving case management services. The tool will also gather data that can help the Commonwealth and its partners better understand the needs of vulnerable Pennsylvanians and identify service gaps across the state. By looking at critical social determinants of health, including employment, childcare, transportation, food security, access to healthcare and housing stability, the Commonwealth and all network organizations can help individuals achieve better long-term outcomes and maximize the impact of healthcare dollars. So this is just letting you know that the Department of Human Services has the plan all laid out. Now they are seeking bids from experienced vendors so DHS can roll this out. Thank you. That's the end of my presentation, and I know we have some more payer updates that Sharon DeSantis will be happy to present. Thank you. Sharon, you're up.
Thank you, Deanne. Thank you very much. So we're going to move on to other payer updates. First up is United Healthcare, and they have quite a few updates to bring that we're going to bring to you today. Earlier this year, they introduced their premium program designation for physicians. There are 16 specialties that actually represent 47 credentialed specialties that are included in the program. For instance, gastroenterology includes digestive diseases, hepatology and liver disease, and gastroenterology specifically. The program evaluates and recognizes physicians who meet standardized quality and cost efficiency criteria and uses claims for dates of service 1/1/17 through 2/29/20, which they made sure was prior to the declaration of the PHE. The timeline reflects that these designations are going to display in care provider directories within a week of that date that you see there, September 25th. You can request a reconsideration of the designation that you receive, but no later than November 27th. And then if applicable, they'll update the designation, meaning United Healthcare, after the reconsideration case is complete. And we've provided the link so that you can look up a little bit more information. Still on United Healthcare, social determinants of health. They are, quote unquote, strongly urging the documentation of social determinants of health using ICD-10 codes in the member's record, especially as of October 1st, 2020. It's going to apply to all the United Healthcare members, including Medicare Advantage, Medicaid, and individual and group market plans. They've issued a protocol document that has a little bit more detail to it, which we've included that link. Take note if you do review that. It also includes information regarding their right to audit claim submissions retrospectively. So it's vital that everybody be trained on the ICD-10 codes that capture SDOH to ensure complete and accurate medical diagnosis, record keeping, and your claim submission. Onboard Pro credentialing. United Healthcare is introducing this as their new credentialing tool on the Link website. That's Link as the name of the website. It's eventually going to replace their RFP, which is their request for participation portal. Onboard Pro is, they say, will simplify and speed up the process to join their networks by connection directly to CAQH ProView. If you need to make demographic updates for your practice, use your current process. Onboard Pro is going to be for new care providers that come on board that aren't yet linked to your group's contract. You'll receive an email when Onboard Pro is available for your TIN, your tax ID. If you've not used the Link website before, if you're not familiar with it, you need to register for an Optum ID. And we have more contact information if you need more help with this. United Healthcare has also, effective this past July, they say that certain, and I put certain in quotes the way I'm reading it, United Healthcare commercial members no longer had benefits for out-of-network lab, dialysis, and durable medical equipment services. Physicians and other QHPs are required to inform these members when involving an out-of-network provider in their care for non-emergent services. And it needs to be on a member consent form, which we've included for you. There are a number of penalties, unfortunately, if this consent is not obtained, such as a decrease to your fee schedule, holding you financially responsible for any costs collected from the member by a non-participating care provider, or even termination of your agreement. And again, we've included the update and the member form for you for your use. Smart edits. This is another announcement from United Healthcare, and it has to do with catching the billing errors within claims, which obviously can be a daunting task. The one thing you want to be able to do when after you see a patient is send out a clean claim. Smart Edits is a claim processing tool that can help you catch some of these things and perhaps even resolve them before the claim is processed. You'll see an edit message on your clearinghouse rejection report within 24 hours of submitting the claim. There are more than 200 smart edits with different varying types. There are 3 of them. Already existing are return edits, and those are sent when when the claim you submitted may be delayed or denied due to potential billing errors. The new one is rejection edits that was added last month in August. And that will be sent when claims are automatically returned due to being a duplicate, or if it doesn't contain a valid CLIA certificate number. And again, already in place is the informational edits and banners. They're sent to you to let you know about additional information on any upcoming reimbursement policy changes, which could be helpful. And again, we've included a few links by way of support and training. EFT payments, electronic fund transfers. United Healthcare has come out with an announcement that there's a delay for the electronic payment solutions rollout for commercial plans until further notice. There's a push to eliminate paper checks and replace with electronic payments. United Healthcare is not the only one, but you'll have the option with them of signing up for the automated clearinghouse, the ACH as it's called, or direct deposit, the preferred method of virtual card payment, or to receive a payment by a virtual card. Medicare Advantage plans are scheduled to move to this later this fall, with community and Medicaid plans next year. If your practice is still receiving paper checks, you can enroll in ACH direct deposit for your claims payments. If you don't elect to sign up for the ACH direct deposit, then a virtual card will be automatically sent in place of paper checks. But remember that there is typically credit card processing fees that may apply to those virtual cards. The next payer is Capital Blue Cross. We've talked about this before. They have added enhanced encounter visits earlier this year. This is a Medicare Advantage benefit. The goal is to make it easier for members to maintain overall health care. It can be provided along with annual wellness visits or regular office visits with their PCP. It has to be a face-to-face in-depth assessment for each of the known health conditions, and any preventative services need to be addressed, any gaps in care. A med rec is also required during this visit. You can use telehealth, but the only way that telehealth would be permitted is if it's audio and video. When billing for it, you would use a line item with a procedure code T as in Tom 1015, and then also the XU modifier. And then the reimbursement is to be $150, available once per calendar year. Capital Blue Cross also really talking about social determinants of health. They are another payer who's urging providers to help identify the social determinants that influence an individual's health and well-being by utilizing those ICD-10 codes that correlate, for example, homelessness, low income, alcoholism, and drug addiction in the family. The administrative bulletin does outline an effective date of September 1st. It does apply to all of their plans. And again, they're urging providers to please begin identifying patients this way. Highmark, we found a policy in their provider manual from July, which describes the treatment of immediate relatives. Reimbursement may not be made for charges imposed by the professional provider for his or her immediate relatives or members of his or her household, or for services rendered by a professional provider for himself or herself. The intent is to bar payment for personal services of professional providers that would ordinarily have been furnished gratuitously. Immediate relatives are defined in the policy. There's a list of what they consider to be immediate relatives, as well as what they consider to be member of household. On the other side, though, payment may be made for charges imposed on immediate relatives or household members by the provider to recover expenses incurred in furnishing covered items or supplies like drugs, biologicals, prosthetic devices, that sort of thing. They will reimburse for that. Moving to Cigna, they have a few enhancements with regards to claims submission. Faster option is now available when you need to submit supporting documentation for them when they ask for it. And that's in order to process and pay, the pending claim faster. Using the process guarantees quicker reimbursement. Once logged in, you'll upload your documentation directly. And we've included a link if you want to register for that. That's on the Cigna for Healthcare Professionals website. The other one is enhancements for a quicker redetermination. That's going to be available a little bit later this year. You'll save time by submitting documents, claims reconsideration requests via, again, the Cigna for Healthcare Professionals website. So there's no need to call or fax or mail. You can even add notes to explain the request and attach any supporting documentation. And if you want to view the status as it moves along, you can do that too. Online reconsideration for appeals is expected to be available later this year in 2020. AmeriHealth and Keystone First. Again, offering electronic reimbursement policies and options. They're moving to electronic reimbursements, so they're offering more choices in payment methods. They've partnered with Change Healthcare and Echo Health. If you're currently receiving EFT payments from the plans, your payments will continue to be transmitted electronically. If you're not currently registered to receive the payments electronically, you'll automatically receive the VCC payments, or you have to opt out. You'll see the information is there to call and opt out. If you're new to EFT payments, you'll need to enroll. The link is there on our slide. And you can log into providerpayments.com to access a detailed explanation of payment for each payment from the plans. And the last item I have is from Keystone First. If you're still receiving the patient panel rosters on paper in an envelope each month or each quarter, that's going to be discontinued as of September 1st. They will no longer be provided. The report is still available on Navinet, and you're encouraged to access them routinely as they'll show you care gaps so that you can, help your patients complete some of those and close those gaps, like adult preventative care visits, that sort of thing. The change will apply to Keystone First, as well as Keystone First Community Health and Keystone First VIP choice providers. The link to the announcement, if you'd like to read it, is on the slide. At this point, I am going to turn the program back to Jennifer for our final slides. Thanks again for attending, and we appreciate you and giving us your time and attention today.